I am Dr. Helen Price. I'm a parasitologist and co-lead of ECLIPSE.
I'm Professor Lisa Dikomitis, an anthropologist, and with Helen, I co-lead this interdisciplinary global health program.
I'm Dr. Brian Wenning, an anthropologist in the ECLIPSE UK team.
And I am Dr. Kay Polidano, a sociologist also in the ECLIPSE UK team.
Welcome to this introduction to ECLIPSE. This is a 4-year programme that has been awarded £4.6 million by the UK's National Institute for Health Research, or the NIHR. ECLIPSE stands for Empowering People with Cutaneous Leishmaniasis, intervention programme to improve patient journey and reduce stigma via community education.
Before we start, it is important to state that the views we express in this video, or those of us, are not necessarily those of the NIHR or the UK's Department of Health and Social Care. And as you can see, we are recording this video during the COVID-19 pandemic, each from our own homes, so forgive us for any technical disruptions or any problems with the slides.
So ECLIPSE is a large global health family, as you can see on the slides, and in addition to the team at Keele University in the UK, ECLIPSE has teams at the Federal University of Bahia in Brazil, Mekelle University in Ethiopia, and Rajaratnam University of Sri Lanka.
The beauty of ECLIPSE is the interdisciplinarity of the project. Our large team includes anthropologists, parasitologists, dermatologists, psychologists, sociologists, public health specialists, and general practitioners.
The ECLIPSE team works around leishmaniasis. This is the disease resulting from infection with a tiny parasite called leishmania, which resides inside white blood cells of the host. It is important to note that leishmaniasis cannot be spread by direct person-to-person contact. Leishmaniasis is quite unusual in that there are 4 very different types of the disease.
The most common type of leishmaniasis is cutaneous leishmaniasis, or CL. This accounts for over 75% of all leishmaniasis cases, and in CL, most of the parasites remain in the skin and cause 1 or more lesions. CL is sometimes painless, but there is a risk that other pathogens, such as bacteria, will enter the broken skin and cause secondary infections, leading to pain and sometimes an unpleasant smell as well.
A complication of CL is mucocutaneous leishmaniasis, or MCL, and this develops in a small percentage of patients after they have had CL. The parasites invade the mucous membranes, particularly around the face, affecting the nose, the mouth, and the ears. And this can be very destructive and lead to severe damage to the face.
CL is often described as being self-healing, but there are many arguments for diagnosing and treating people who have such CL skin lesions. Some lesions heal much faster than others. If we do not treat CL, there is a greater risk that the parasites will be spread via sandflies to other people. Untreated lesions will grow larger and there's a greater risk of scarring and of larger, more noticeable scars. There is also a risk that the lesion will become infected by bacteria, and this can make the skin very painful.
The current treatment options for CL are very limited, and no treatment is ideal. The most commonly used treatment is a series of daily injections with drugs known as pentavalent antimonials. These are based on the heavy metal antimony, which is very toxic. The drug needs to be injected daily for several weeks and can cause unpleasant side effects ranging from nausea and fatigue to problems with the heart, kidney, and pancreas. There is only one orally administered drug for leishmaniasis, moltefosine, but this can cause birth defects and cannot be given to women who may be pregnant or to children.
So CL is found in 98 countries, and the World Health Organization reports over 1 million new cases each year. CL is most common in areas of extreme poverty and poor sanitation, where sandflies tend to be numerous. So this potentially highly stigmatizing skin condition often leads to discrimination, social exclusion, and further poverty, which in turn may lead to additional mental and physical health problems. So to date, most research on CL was single disciplinary. So that means that parasitologists focused on the parasite and drug development, health service researchers explored, for instance, barriers and facilitators to treatment, or anthropologists, for instance, focusing on societal factors.
Our ECLIPSE program brings researchers from many disciplines together for an applied global health project underpinned by anthropological theories. So it's important to note that we do not work in the lab in ECLIPSE, but rather all research activities take place in CL-affected communities. And we'll say a bit more about this shortly. But it's really important to capture different understandings and perspectives of the disease, as the experiences and challenges that people with CL face may be very different worldwide.
And you can see the ECLIPSE aims on the slide here. And to achieve these aims, we have 3 phases in ECLIPSE. First, we explore how CL actually exists in each country. Qualitative fieldwork consists of long-term ethnographic fieldwork, so participant observation in the communities, but also interviews, focus groups, and other forms of participatory and creative methods, but also quantitative research via surveys to measure stigma. These findings will then inform context-specific and culturally bespoke ECLIPSE interventions for each community. And one intervention will always be based in the community and serve to raise awareness and/or reduce stigma, while another intervention will be a training package for community health workers and healthcare professionals. Finally, these interventions will be evaluated to actually make sure we know what their usefulness is to both individuals and communities. And you will notice that community engagement and involvement underpins the whole ECLIPSE program. Each stage of ECLIPSE is conducted with collaborative input and the experience of community members.
The 3 countries in which we work, Brazil, Ethiopia, and Sri Lanka, offer 3 very different disease realities in terms of socioeconomic, political, cultural, and health service factors. Brazil is known as an upper middle income country. CL has been endemic in this country for a long time. And because of this, public campaigns on identification of the disease and prevention measures have ensured that awareness is quite high in some local communities. As you can see from the first picture in Brazil, a dedicated leishmaniasis centre even exists in a highly endemic part of the country.
Now, Ethiopia is actually quite the opposite of this. It is classed as a least developed country, and whilst it also has a history of CL, there are no really official numbers concerning cases, as it is not mandatory to report CL. Furthermore, awareness of the disease is very low and is coupled with stigmatization of those with the lesions. Hospitals for diagnosis and treatment often involve traveling quite long distances, and that, coupled with the costs of treatment and missed work, mean that most actually do not seek biomedical treatment, but rather turn to home remedies or traditional healers.
Sri Lanka, a lower middle income country, offers a different CL reality yet again. So unlike the other 2 countries, CL is quite new and represents an emerging public health issue. The first case was only reported in 1992. So though it's now required to officially report CL cases, given this relatively new presence, awareness among health professionals and the general population alike remains quite low.
For a program like ECLIPSE, where we are working with so many different communities in different countries, each of which might have their own challenges, their needs, their nuances, it is extremely important to engage robustly with the community members and to seek to gain their acceptance, their trust, and where possible and how much possible to dissolve hierarchies by collaborating with community members at every stage of the research program and of all processes, and of course co-producing ECLIPSE interventions. Decolonizing ECLIPSE research involves working with community members and allowing them to influence the direction of the research in a way that they see useful and beneficial. And as part of our decolonizing agenda, ECLIPSE not only works in, with, and for communities, but is also committed to the idea of South-South collaboration.
Now, South-South collaboration refers to countries in the global South working together to share knowledge and find solutions to common problems. By encouraging the sharing of knowledge and practices of countries in the global south, these countries can then position themselves as experts on the problems that they face. And we're mindful of different challenges in doing this. And to overcome these as much as possible, we're involving community members and other stakeholders in our program throughout. And this is why it's essential that our plans are culturally appropriate and bespoke to each context. And although community engagement is very different in each ECLIPSE country, we can still learn from each other.
The ECLIPSE community engagement strategy is based on the establishment of two types of groups: community level groups and policy level groups, each having their own function with regard to engaging and involving different stakeholders and community members in the ECLIPSE programme. Community level groups take the shape of community advisory groups, or CAGs. These are situated at a field site level, which is often village level. They comprise mostly of people with CL, community leaders, traditional healers, and religious leaders, and other community members.
Now, our aim here is to gather community members together at regular interviews, so we seek input and make joint decisions about different aspects of the ECLIPSE program, such as public-facing material, participant recruitment processes, research activities and how to make them culturally appropriate, development of interventions, the interpretation of findings, and various other issues which we will encounter along the way. So since members of these groups actually live in the ECLIPSE field sites, they are also in a great position to act as ECLIPSE ambassadors. So thus helping to bridge the relationship between ECLIPSE researchers and the rest of the community. Now, as we can see from this diagram, this type of engagement is quite inward looking, meaning that it includes people who live or work in the ECLIPSE field sites and focuses specifically on how research activities are to be implemented in the communities.
So you can see here ECLIPSE researchers with community members in these pictures. Ethiopian team members and community members on the left, and Brazilian team members and community members on the right. And even at first glance, I think it's obvious that the wider context of the field sites in which we conduct research in these two countries, and of course Sri Lanka as well, not pictured on these slides, are different in terms of, for instance, physical infrastructure. Okay, but other contextual differences include most of transports to the field sites and in the field sites, literacy levels of community members, and of course, local customs, traditionals, health belief, practices. What may be viewed as culturally appropriate in Brazil could be deemed as unacceptable culturally in Sri Lanka. All such factors and many others we take into consideration and into account in the organization and in the operation of these community groups. Adaptability, if we can call it like that, is crucial, because in ECLIPSE we want to steer away from a one-size-fits-all model of community engagement. We want to ensure that whatever we do is context bespoke and is culturally appropriate.
The other part of our ECLIPSE CEI strategy is based around policy level groups. These groups are intended to be at an urban regional level and target primarily stakeholders who are able to bring about policy change in the ECLIPSE region and beyond. These include clinicians, public health officials, religious and municipal leaders, NGO representatives, regional health officers, and ideally also people with CL to have that insider perspective.
And as you can see from this diagram here, the focus is outward looking, as the goal of these group meetings is to discuss and develop strategies of how we could use what we're finding in the ECLIPSE communities to promote change. So for example, through a change in policy or practice, both within country and hopefully also beyond. And the role of members invited to this group is therefore to cascade ECLIPSE findings and ECLIPSE interventions upwards to policymakers in other regions of the country.
Finally, in this introduction to ECLIPSE, it's also important to stress that our program of research is underpinned by the biopsychosocial model. Now, in contrast to the biomedical model, that is a model that sees disease purely as a biological event, in ECLIPSE, we regard CL at the intersection of biological, social, and psychological factors. So from this perspective, therefore, stigma related to CL is not inherent in the condition itself. Stigma stems from people's beliefs, their attitudes, and their responses, which in turn are always very much shaped by the local social-cultural context.
Now, it is clear from the CL literature that whilst a country like Colombia, where CL scars are highly stigmatized as they have political undertones associated with them, as these are typically found among guerrilla fighters in the jungle. In Turkey, for instance, these scars are sometimes considered to be a beauty mark, especially by the older population. In Saudi Arabia, for instance, they are often referred to as the little sister because of how common they are. These examples demonstrate that we should not start our research with a taken for granted assumption that CL is indeed stigmatized, but rather remain open. It is important to take into account culturally and locally constructed meanings of CL. These have very real implications in people's everyday lives on both a personal level, for example, whether they choose to access treatment or not, and also on a policy level, in terms of what resources are allocated for this patient group and so on.
If you're interested in learning more about the ECLIPSE project, please check out our website, follow us on Twitter, or you can email us. Thank you.